Everybody, it's Dr. Eric Malkavich. We're back for another edition of Thyroid Thursday. Today we're doing another lab review. I think this is lab review 17. And this is a person who presented to my office for some help with her thyroid, health and her overall health in general. So let me give you a little bit of the backstory. This is a person who's generally pretty healthy person, really focused on health and well-being, healthy eater, healthy lifestyle, a lot of things right, seasoned integrative practitioner, and get some blood work done. And this was all that was initially presented was TSH 4.86, free T4 1.3, free T3 2.8, free T3 to free T4 ratio, which is what I calculated at 0.28. So this is a person who didn't have a lot of signs and symptoms. This is a person who's in their 60s, I believe, and feels pretty good. Maybe has some tiredness and fatigue, but this is a person who's in their 60s, right? And they're just focused on trying to be healthy. Their integrative or functional practitioner looks at these labs and diagnoses this person with primary hypothyroidism. So you have primary hypothyroidism, TSH is 4.86, that's too high. Free T4, free T3, I guess they're looking at the free T3 and saying that's too low. And that's really all that they were taking a look at. So the person gets prescribed 1 grain of Armour, and within a short period of time goes back to the doc because they're feeling more hyperthyroid, they're having anxiousness, anxiety, irritability, and their TSH is now plummeted. And they're not feeling great, and the doctor starts manipulating the doses of thyroid medication to try and find the dose that's going to make her feel better and potentially optimize her labs for whatever that means. That's the big term in functional medicine. We need to optimize you, and I'm confused as to what that means for a lot of people. So this has been a 3-year journey of going up and down in medication. She's had some improvement of some of her symptoms. Some symptoms continue to get worse. The biggest thing over the last 3-year escapade has been that she's continually gaining weight. So this is on thyroid medication. This is a person who was fit, exercises regularly, ate a really clean whole food based diet, never really had a weight issue until she started on thyroid medication for this diagnosis. She keeps titering with her, her and her doctor keep increasing the dose, changing doses. Right now she's down to 1/2 grain of Armour because that's where she kind of feels less hyperthyroid, less anxiousness, less anxiety, less brain fog. But her biggest complaint over the last 3 years is just the weight gain. So she's reaching out to me, and we have this conversation regarding the labs that she presented. Now, for me, I would prefer a comprehensive metabolic panel that looks at a full thyroid panel, which this is not. I know a lot of docs today, they'll only run free T3 and free T4. I don't think that's good enough. I think we need to take a look at total values as well. I think you want to take a look at reverse T3. You want to take it to total T4, total T3. I think T3 uptake is important to take a look at. Thyroid antibodies, yeah, you can get those done. I think they're important, but not necessarily something that's important to run all the time. But we need to run more than the thyroid panel. We need to run lipids. We need to run inflammatory markers. We need to look at what's going on with the blood glucose. How is what we see in a thyroid panel impacting the rest of the person's chemistry? How's it impacting their blood glucose regulation? How's it impacting their lipid physiology? How is it impacting their liver? How's it impacting their renal system, their adrenal system? If you don't look at the rest of the labs, how do you know how the thyroid physiology might be impacting those systems? Sure, you can have a free T3 that looks good, but that may be in the bloodstream and not what's impacting, say, the muscle tissue or some other tissue, okay? So in this situation, we started a discussion with whether was prescribing thyroid medication appropriate, and was this or is this primary hypothyroidism? Is this a gland that can't make enough thyroid hormone, and is this a person who should have been prescribed thyroid medication? So let's take a look at it. The lab reference range is like 0.45 to 4.5 at a lot of the labs. Now, the guidelines, there's arguments about the guidelines about not treating people until they're over 6, maybe closer to 10 for hypothyroidism before we start giving them medication. So this person's only at 4.86. This person's just above the lab reference range. Now, we don't have total T4 to see how much thyroid hormone is being generated by the thyroid gland. We don't have total T3, but we have free T4, and it's at 1.3. That's well within the lab reference range. So she could have low total and a normal free, but that doesn't appear to be, that may not be the case, but we don't have it, but free T4 is 1.3. There's enough T4 that's free to be able to convert to T3 and free T3. And free T3 is a little below what somebody might say is an optimal range, but still within the lab reference range. And this is a person who's over 60, so we should expect TSH to be a little bit higher as we get older. And what this patient didn't realize, but I just had a podcast with Joe L. Corey about timing of thyroid panels. This was a thyroid panel that was done, I think, in the fall or the winter. And in those situations, TSH tends to be higher. So is this truly primary hypothyroidism? The answer is no. This would be at best diagnosed as subclinical hypothyroidism. And there's lots of arguments whether we should treat people or we shouldn't treat people. If this was a person who's overly symptomatic, maybe somebody would make the argument, well, let's just give them thyroid hormone. Let's give them some T4 to make them feel better, or let's give some T4 and T3 to make them feel better, as in Armour or NP thyroid. If the person's asymptomatic, why would we give them more hormone? TSH can fluctuate. That's what it's supposed to do. If free T3 goes down a little bit or T3 goes down a little bit and we need to drive up more thyroid hormone production, TSH goes up. If this is a person who's got a bit of an iodine deficiency, TSH may go up to help maintain the level of T4 and T3. So should this person have gotten thyroid medication? I don't think so. And if we look at the free T3 to free T4 ratio, it's below the reference range. So typically when we see somebody who has primary hypothyroidism, even if they had low T4 and low T3, the free T3 to free T4 ratio, it tends to be higher because as quick as they're getting T4, the body's converting it to T3 because we have to maintain a certain level of T3. And this free T to free T4 ratio is below the reference range is 0.31 to 0.34. So this would be a person that I would say, even though the TSH is slightly elevated, whether they're overly symptomatic or not, I wouldn't recommend getting thyroid medication because there's enough T4 to convert T3. If there's a reduced conversion of T4 to T3, it's probably an adaptive response. So now we want to look at the rest of their labs, look at the rest of their health history to see, is there inflammatory mechanisms going on? Or is this a person, if this person's asymptomatic, do we just leave it go, retest it somewhere in the future? If the rest of our labs don't look like there's a hypothyroid condition going on, this may be a non-issue. Now, if this person was truly symptomatic, I even though I don't prescribe, I would not recommend that they start thyroid medication because they already have enough T4. You have a reduced conversion to T3, and that's usually an adaptive response to some type of cell stress inflammatory mechanism. So more thyroid hormone in this situation wouldn't be beneficial because the body's already favoring the deactivation potentially. So what we really should do is, if this person's symptomatic, is say, okay, what's resulting in the reduced T4 to T3 conversion? Is there an inflammatory mechanism? Is there dysbiosis? Is there disrupted sleep patterns? All the things Dr. Kelly and I talk about in the book that trigger that cell stress response. But once she was given a grain of Armour, you can see what happened. Her TSH plummeted. So you put a whole bunch more T4 and T3 into a system, especially one that's got some type of inflammatory mechanism going on, and you're going to drop TSH because T4, T3 in circulation saturates the hypothalamus pituitary, shuts down TSH. Why did she start to feel worse at this value? Because she wasn't taking enough thyroid medication to replace what she would make in any given day, and it tanked TSH, which then resulted in her gland not making the thyroid hormone. So all in all, is this a person who should have been on it? No. They should not have been prescribed thyroid medication in my opinion. I'm not a medical provider. I don't prescribe medication, but in my opinion, this person's 3-year odyssey of trying to fix their thyroid physiology was caused by the person who prescribed this medication. My 2 cents. If you have any questions, put them below wherever you watch this video. Thanks.